Hello, this is our Veterans Project for Nursing Care for Adults 1, and the members of the project is Julia Mendes Iglesias, Sean Romero, Franz Gerald Neret, Vladimir Vilvorn, and Gianna Vargas Trujillo, and we are Group 5, and our main topic is traumatic brain injury. So the main topic is traumatic brain injuries, and it actually refers to the head injuries caused by bullet penetration, violent impact, or shock waves from explosive weapons are the main causes of military TBI, which had a long been under debate for being an organic disease, which is a neurological disease, or a functional disease, which it means psychiatric disorder. So multiple studies support the link between single moderate severe TBIs and Alzheimer's disease, Parkinson's disease, and ALS, amyotrophic lateral stenosis. So, in military settings, most TBIs are mild TBIs for the U.S. forces deployed to the Afghanistan and Iraq in Operation Enduring Freedom, Operation Iraqi Freedom, and Operation New Dawn. Blast exposures is the leading cause of a mild TBI, although services members are also susceptible to concussions. The first largest scale evidence of military-related mild TBI occurred in World War I that happened in between 1914 and 1918. In association with the frequent use of high explosive in track warfare, services members who experience high doses of the explosive artillery fire sometimes developed shell shock or commotion cerebri, a mysterious condition characterized by headache, amnesia, inability to concentrate, difficulty sleeping, depression, and suicide. Moderate to severe TBI is associated with the progressive atrophy of gray and white matter structures that may persist months to years after injury. In addition, multiple studies support a link between the single moderate TBI and Alzheimer's disease, Parkinson's disease, and ALS. So on this slide, it's basically a picture of the veterans' worst wounds, maybe the ones you can't see, and it's just a nice picture of the brain. So the most important wars were World War II that happened between 1939 to 1945, then World War I, 1914 to 1918, Cold War, 1947 to 1991, American Civil War, 1861 to 1865. We had the French Revolution and Napoleonic War, 1789 to 1815, 30 Years' War, 1618 to 1648. So soldiers often suffered TBIs after war due to multiple factors inherent to combat environments. Exposure to explosions, blast, gunfire, and shrapnel increases the likelihood of direct head impacts or exposure to blast waves, leading to TBIs. The widespread use of improvised explosive devices in modern warfare exacerbates this risk, causing widespread injuries even to those not in close proximity to the blast. Additionally, soldiers may experience repetitive mild trauma from training exercises, falls, or vehicles accidents, contributing to cumulative neurological damage. Despite advances in protective gear, soldiers may not always wear helmets or other protective equipment properly, leaving them to vulnerable head injuries. Furthermore, the psychological impact of combat, including stigma, fear removed from duty, and concerns about appearing weak, may deter soldiers from reporting TBI symptoms, leading to underdiagnosis and undertreatment. Overall, addressing the prevalence of TBIs among soldiers require comprehensive strategies for prevention, early detection, and effective treatment to support the health and well-being of the military personnel.
Most studies published on TBIs in the military were published after 2006, and these studies were shown that TBIs were the most frequent blast-related injury. The service branch with the most TBIs is the Army, and the Defense and Veterans Brain Injury Center estimates that between 2000 and 2019, 413,858 service members were diagnosed with a TBI. And since 2000, about 376,724 service members have been diagnosed with at least one TBI. And the group with the highest incidence rate of TBIs were Caucasian males aged between 17 to 24 years old who were deployed in the Army, and the incidence rate for them were 5,583.82 per 100,000 person years. And pressure years refers to an estimate of the actual time at risk to sustain a TBI. From 2000 to 2011, 1,811.4 TBIs per 100,000 service members were discovered. The incidence of TBI is 92% higher when deployed, and this obviously makes sense due to the fact that when these service members are deployed, they are in contact with combat, explosives, and any other risk. In the next slide with the chart, shows different numbers of service members with TBI. It categorizes them by gender, age, race, the branch of service, the component of service, and deployment. And some of these numbers may be skewed because of the population in the military. There are more Caucasians than any other race in the military, and there are more males than females. Excuse me. And also, the Army has more service members than any other branch, and they are more involved in ground combat, than any of the other branches besides the Marines. And this has them at risk for explosive devices that can cause and injure them for them to sustain a TBI.
Hello, my name is Juliet Mendez Iglesias. In the next two slides, I will be talking about mortality and morbidity of veterans with traumatic brain injuries. First, let's start with mortality. Traumatic brain injuries represent a significant concern for veterans, particularly those who have been exposed to combat or other traumatic events during their military service. Recent research, as highlighted in the article Association of Traumatic Brain Injury with Mortality Among Military Veterans Serving After September 11, 2001, published by JAMA Network Open, shed light on the heightened mortality risk faced by veterans with TBAs. This study underscores the sobering reality that veterans with TBIs experience substantially higher mortality rates compared to the general population. Even after accounting for various demographics and medical factors such as age, sex, and comorbidities, veterans with TBAs exhibit a 2.2-fold increase in mortality risk. This elevated risk persists beyond the immediate aftermath of the injury, emphasizing the long-term implications of TBIs on veterans' health and well-being. So in this slide, we will be talking about morbidity. So beyond mortality, TBI among veterans are associated with a complex array of long-term morbidities that profoundly impact multiple facets of their life. The aforementioned study provides valuable insight into the diverse morbidities experienced by veterans with TBI, encompassing cognitive, psychiatric, and physical domains. Cognitive impairments are prevalent among veterans with TBA, manifesting as memory deficit, attention problems, and difficulties with executive functioning. These cognitive challenges not only impede veterans' ability to perform daily tasks, but also diminish their overall quality of life. Furthermore, TBI frequently co-occur with psychiatric disorders such as post-traumatic stress disorders, PTSD, and depression, creating a complex interplay of mental health challenges that exacerbate their morbidity burden. Additionally, physical disabilities stemming from TBIs, including motor impairments, sensory deficits, and chronic pain, significantly impact veterans' mobility, independence, and functional abilities. These physical limitations often require ongoing rehabilitation and support to facilitate veterans' recovery and adaptation to their new circumstances. Understanding the intricate interplay between mortality and morbidity in the context of TBI among veterans is paramount for developing comprehensive care strategies and support services tailored to their unique needs. By addressing both the immediate and long-term consequences of TBI, healthcare providers and policymakers can strive to enhance veterans' outcomes and promote their overall well being through their post military lives. Thank you.
Assessing a patient with a traumatic brain injury requires a systematic and comprehensive approach to detect any neurological abnormalities. And for that, we got to do a general assessment where we have to assess the patient's level of consciousness with the Glasgow Coma Scale. Note any changes in mental status, orientation, and cognitive function. Assess for confusion, disorientation, memory deficits, and attention span, and also monitor vital signs. For the neurological assessment, we have to assess motor function, sensation, and reflexes, assess for weakness, paralysis, and asymmetry, evaluate muscle strength and tone in all extremities of the patient, test sensation in different areas of the body, check also for deep tendon reflexes, and assess cranial nerve function. As we follow with the head and neck assessment, we have to assess the head and scalp for any signs of trauma, any lacerations, tenderness, or fracture. Check for any clear drainage from the nose or ears, which would mean cerebrospinal fluid leakage. Assess neck mobility and stability for any cervical spine injury or instability. For the respiratory assessment, we have to monitor respiratory system and monitor O2 sat, assess lung sounds. For the cardiovascular assessment, we have to monitor the cardiovascular system and assess for any signs of cardiac dysfunction. And at last, for the skin, we have to assess the skin for signs of pressure ulcers, abrasions, or other injuries.
In terms of nursing interventions, we will talk about the ineffective cerebral tissue perfusion, the acute confusion, and the deficit knowledge. For the ineffective cerebral tissue perfusion, we'll evaluate and monitor pupillary responses. We'll monitor the patient bilateral motor responses and maintain head or neck in midline or neutral position. We'll also provide rest periods between care activities and limit the duration of procedures. We'll administer IV fluids, supplemental oxygen, and medication as indicated. And finally, we will prepare for surgical intervention as indicated. For the acute confusion, we'll ensure patient safety. We orient the patient as needed. Keep explanation and activities short and simple. Eliminate extra noise as necessary and provide structure, therapies, and activities. For the deficient knowledge, we'll encourage the patient to participate in developing a relevant treatment regimen. We'll also encourage the patient and family to participate in required therapies. We'll discuss possible changes in behavior, mood, and personality at home, and the importance of follow-up care. And finally, we'll instruct the family to develop a structure and consistent home routine.
So, as a group reflection, exposed to information about TBIs among veterans can evoke a range of responses regarding veteran health issues. So, learning about the challenges veterans face in the assessing healthcare, reintegrating into civilian life, and managing their condition can foster increased awareness and empathy for their experiences. This understanding may also highlight the systemic issues with healthcare systems or government policies, prompting efforts to address gaps in care and advocate for better support services. However, discovering that some veterans do not receive timely or appropriate care for TBI may evoke frustration or anger. leading to an advocacy for improved resources and accountability. Conversely, examples of successful interventions or programs aimed at supporting veterans with TBI can inspire optimism and sense of hope, encouraging individuals to get involved in similar efforts or contribute to positive change in veterans' healthcare. Overall, exposure to TBI among veterans has the potential to shape attitudes and beliefs, ranging from the increased empathy and advocacy to frustration and a call for improved support services and resources. On this slide, you can see our references. So this is our presentation for the Veterans Project Nursing Care for Adults 1, and it was presented by Juliet Mendez Iglesias, Sean Romero, Franz Gerard Naret, Vladimir Vilbron, and Giamna Vargas Trujillo, and this is the end.